So if we move to TPT, we understand that it is preventive therapy against TB, and we know the importance of knowing who qualifies for TPT. And as it stands, it's all our HIV positive adults, and the pediatric guidelines have not changed in terms of the exposure. We will focus on the children who have been exposed, and we'll get through the details of that. It is using one drug, which is your isoniazid, one TB drug as a form of prevention, and it's given to individuals with latent TB infection. And this is obviously post the screening tool that you'll be using to establish who is TB infected and who has got TB disease. It is to prevent the progression of your latent TB infection to active TB disease, and it reduces the risk of TB by 64% with patients who previously, when we had the previous guidelines which have changed, that are dependent on the TST test, skin test, the reduction would be 64% in terms of prevention of TB disease and 33% overall. If you remember in the previous guidelines as well, we were talking about the value of being both on INH prophylaxis as well as antiretrovirals, and found that the cover or the prevention or of risk is further reduced when a patient is on both. Okay. So if we look at the differentiation then between your latent TB and active TB disease, I think the major things we need to remember here is that with your latent TB infection, the TB bacilli is dormant. And this is important because there used to be that issue of what if the patient does become TB positive, will it not then mean we are, or rather in terms of your defaulters, what happens with resistance issues? We are exposing a dormant bacilli to the INH prophylaxis, so the chances of getting a resistance are less in that instance. But TB bacilli that's multiplying actively, these patients do not qualify for INH prophylaxis. A person has no TB symptoms with latent TB infection, whereas with active TB, they will be symptomatic. So their TB screening would be positive. Latent TB patients are non-infectious, whereas your active TB patient may be infectious and can transmit the TB, and it is a way of preventing death if the patient is initiated on TB treatment. TPT prevents TB disease here, and this patient, by definition, is not called a TB case. The TB case patient is that one who has active TB disease. Okay. So how do we exclude active TB disease then? By using the TB screening tool, all right? This is done in males and non-pregnant female patients. When Kotsega was up here, she spoke about the screening as far as a pregnant woman is concerned. Because the TB screening tool in pregnancy is not reliable, you use the Gene Expert as a screening tool, all right? So TB symptom screening is done, and if the patient has no symptoms, TPT can be considered after the contraindications of TPT have been excluded, and we'll go through those. As far as TB screening in pregnant patients, as we've said, you do the screening tool, but because of its unreliability, you add a TB Gene Expert, and we went through a whole conversation of actually isolating the TB bacilli, especially when the production is low. And bearing in mind that the chances of non-productive cough in an HIV positive client is also something that we see quite regularly, all right? So it is a real concern that we raised that. Then, especially in patients with a CD4 of less than 100, this becomes quite essential as well. Okay, so that's the new change that we need to be cognizant of when it comes to TB screening in pregnant women. If we look at the algorithm that we'll use, a patient comes in and they are screened for TB. If they screen TB positive, they're known as a TB suspect. If they screen TB negative, in inverted commas, we would call them an IPT suspect. So your TB suspect gets investigated, and they are started on TB treatment as long as they are then confirmed to be a TB case. And the case, remember, can be definitive or none, all right? If the TB investigation yields a no TB in this patient, remember that they were a suspect. So we would not be too quick to move them into your preventive therapy. They could be having early signs of TB. We need to wait, because the chances of then treating active TB with monotherapy in this patient are higher. That's why we wait the 3 months. We rescreen the patient after 3 months to decide whether they can then be initiated on preventive therapy. Are we good, colleagues? So your TB negative screened patient is eligible for TPT. You have to first exclude contraindications, and those have not changed. A patient who has active liver disease, a patient who has co-infection, all right? A patient who has active liver disease, a patient who's an abuser of alcohol, a previous defaulter, all right, would not fall into those that are easily initiated as well. And anyone who has experienced hypersensitivity to IPT previously, and a pregnant woman with a CD4 of more than 100. If none of these are present, then the patient is started, and we have reduced the period, or rather stabilized the period to 12 months. If you remember the previous guidelines, based on the TST, you either, based on TST and your immune level, you could actually not qualify at all, right? Others would be 12 months, then there was the 36 months. 36 months, no longer there. Because the reality is we never really implemented the TST test in most of the provinces. So we ended up with more patients who were not on preventive therapy while awaiting the TST to be available, all right? Are we together? All right. So in summary, who then is eligible for TPT? All HIV-infected non-pregnant adults, your adolescents, whether on ART or not on ART, who have not completed a course of IPT before and who have no signs of active TB at the time. Your pregnant women who have a negative gene expert without any symptoms and have a CD4 of less than 100 would qualify for therapy. And then former TB patients, provided that their treatment was completed successfully and confirmed to be either cured or completed TB treatment. Are we good? Great stuff. Right, and who is not eligible? A confirmed or suspected active TB patient, a pregnant woman with a CD4 count of above 100, your active acute or chronic liver disease, history of adverse reactions to INH, as well as excessive ETOH use. All right. So let's remember that this is the major change as far as this guideline is concerned, and let's communicate it adequately when we cascade. The regimen does not change. It is still INH 5 milligrams per kg per day with a maximum dose of 300 milligrams per day. This is for 12 months across, all right? Pyridoxine 25 milligrams per day to prevent the peripheral neuropathy that may result as a side effect. And clinical monitoring at every visit remains important. We have to assess that the patient is adherent on treatment. We have to make sure that they are free of side effects, and we must screen them for TB so that we never miss that period when they actually convert to be an active TB disease patient and eventually start to treat TB with monotherapy and cause resistance, of course. So that is very important as well. It was quite a confusing message, you know, and quite confusing for most of our clinicians on the ground in terms of the length and duration. Rather the duration of the IPT. So no TST required anymore to determine the IPT duration. In children, we would screen all children for TB at every visit, all right? And this is also what IMCI tells us. Ask about TB contacts, and the contact with a TB-infected person within the last 12 months would then warrant that this person or this baby be investigated. Ask about the TB symptoms, coughing, fever, loss of weight, as well as night sweats. And if positive and there's no active disease, then you offer IPT for 6 months if there's a TB contact that this client has got. And in all children less than 5, all HIV positive children up to 15, this is the guideline we'd use. The dose in children is 10 milligrams per kg with pyridoxine for 6 months as well. And we have to repeat their prophylaxis every time that there's an exposure. So in summary, these are the differences. A child with a positive TB contact may be eligible for IPT if they are less than 5 years old or they are HIV positive. IPT is for 6 months, and IPT is given with every new exposure. In adults, any HIV positive adult is eligible for IPT regardless of the presence of a known TB contact. IPT here is 12 months and usually given once per lifetime. So there used to be that 18 months, school of thought to say they only covered for 18 months, then you must repeat it again. That has actually been, has fallen off.